Welcome back. In this video, I will discuss a very important topic, systemic lupus erythematosus, SLE. As many of you know that it is a multi-system autoimmune disorder, and in this there is production of the autoantibodies against the nuclear antigens. So anti-nuclear antibodies are formed that lead to widespread inflammation and tissue damage. So it is a multi-system autoimmune disease that is characterized by formation of antibodies against nuclear components, leading to widespread inflammation and tissue damage. What are its risk factors? There may be genetic predisposition like you have HLA-DR2 or HLA-DR3. Also some environmental triggers like UV light and certain infections and hormonal factors because it is more common in females as compared to males. And certain drugs also trigger drug induced lupus like hydralazine, isoniazid, procainamide, and minocycline. These are the classic drugs that lead to drug induced lupus. So these are risk factors. Clinical presentation. How a patient presents to you. First, we have general symptoms like we can see in other autoimmune disorders: fatigue, fever, weight loss, malaise, and musculoskeletal pain, and arthralgias and arthritis. This arthritis is non-erosive as compared to that seen in rheumatoid arthritis. This arthritis is non-erosive. Also, patients have myalgia. So these are general features: fatigue, fever, weight loss, malaise, arthralgias, myalgias. But then we have specific features like malar, butterfly rash. This is seen on these cheeks. Then photosensitivity. The patient when goes to sun, then he develops a rash due to sun exposure. Discoid lesions. These are round, as name shows that discoid. These are round rashes that appear on the skin. And there may be oral or nasal ulcers, and these are present on the mucosa. And these ulcers are actually present when there are disease flares. So in disease flares, these ulcers mostly develop. Then patient has alopecia. There is fall of hair from the head and from beard. Then there is renal involvement. Renal involvement leads to lupus nephritis. It has 6 stages. 6 stages. We are not going into detail that much, but lupus nephritis has 6 stages, and most common are stage 3 and stage 4, and these are also very severe. This lupus nephritis presents either as hematuria, proteinuria, and hypertension. Then we have hematologic abnormalities. Hematologic abnormalities are due to antibodies mostly, leading to anemia due to autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia is seen in systemic lupus erythematosus. Then we have leukopenia, low WBC count. Then we have thrombocytopenia, and SLE is also a cause of pancytopenia. Pancytopenia. Then cardiovascular involvement. As this is an autoimmune disease, it causes inflammation. Therefore, there is pericarditis, inflammation of pericardium. Myocarditis, inflammation of myocardium leading to heart failure. Heart failure. Then we have limb and sex endocarditis, in which there are vegetations appearing on the mitral valve mostly, and this is non-infectious but inflammatory condition. Respiratory. It leads to pleuritis, inflammation of the pleura, and pleural effusion, development of fluid between pleura. Then neurological features: seizures, psychosis, and this psychosis is worsened by steroids. So when you use steroids in SLE and patient has psychosis, it is worsened. Then cognitive dysfunction, and it can also lead to stroke in these patients, and transverse myelitis, and other autoimmune conditions can also be caused by SLE. So this is multi-system involvement by SLE. You can see here. Now, how will we diagnose this systemic lupus erythematosus? First one is anti-nuclear antibody. It is almost more than 95% present in the SLE, and you will never diagnose an SLE when there is anti-nuclear antibody absent. So this should be present when you are diagnosing SLE. And for diagnosis of SLE, this ANA is the entry criterion. So ANA should be present. There may be presence of anti-dsDNA in it. Has sensitivity of 60% and specificity of 99%, so it is very specific. And we have anti-Smith antibodies. They have sensitivity of 30% and specificity of 99%. So 30% and 99% and 60% and 99%. So these are very specific for this systemic lupus erythematosus. Then we have complement system. Complement levels C3 and C4 are decreased during active disease. So when there is disease flare, complement levels are decreased. Furthermore, on urine analysis, you can diagnose if it is proteinuria, hematuria. It gives a clue us about the lupus nephritis. There is involvement of the kidneys. CBC shows either anemia, leukopenia, and thrombocytopenia, or it may show pancytopenia, that all of these cell lines may be disappeared. Then we have ESR and CRP. These are the inflammatory markers. These are raised when there is activity. ESR is especially raised, but CRP should be normal when there is lupus. But one thing you should remember, when CRP is abnormal, that is, it is increased, it means there may be certain infections that are causing this increase in the CRP. So infections are the cause that increase in CRP in SLE, but ESR increases with disease activity. Classification criteria, actually it is a diagnostic criteria for this systemic lupus erythematosus. It says that ANA positivity is required for the entry of this criteria. So if ANA is negative, you cannot apply this criteria for the diagnosis of SLE. So ANA should be positive, and there are certain clinical and immunologic features that have certain points, and if more than 10 points, then you can classify it as SLE. The clinical criteria are different, like blood criteria or hematologic criteria. Then we have cardiac criteria, cardiac involvement like pericarditis. Then we have mucocutaneous criteria, mucocutaneous, for example, presence of discoid lupus, etc. And then we have other systemic features. Then in immunologic criteria, you have anti-dsDNA that are very specific, and also anti-Smith. So these things are used to diagnose the SLE, and then we put these points in here, and if these are more than 10 points, then we diagnose it as SLE. Then management. How will you manage this SLE? First one is general measures. Skin protection, because when you go to sun, then it causes development of rash. So sun protection and regular exercise, because of patient has arthralgias. Avoid smoking. Vaccinations. Avoid live vaccines when the patient is on immunosuppression, because when the patient is immunosuppressed, for example, patient is on methotrexate, then it leads to activation of this live vaccine and infection occurs. Pharmacologic treatment. When patient has very mild disease, especially when there is only involvement of skin and joints, then for pain you will give NSAIDs, and otherwise you have to give hydroxychloroquine. Hydroxychloroquine is mostly given as 5 mg per kg per day maximum dose, and hydroxychloroquine leads to retinal toxicity. Then If there is moderate disease requires corticosteroids in tapering doses plus either one of these immunosuppressant medication like azathioprine or methotrexate. These are actually steroid sparing drugs also. These control inflammation in moderate disease. But if there is severe or organ threatening disease, that is disease flare, then you have to give high dose corticosteroids like methylprednisolone. Methylprednisolone. It is given IV 1 gram for 3 days. So it is given for 3 days as pulse therapy, and along with it you can give cyclophosphamide or mycophenolate mofetil, and especially in lupus nephritis you can give this combination is given in lupus nephritis mostly. You can also give in CNS lupus too. Then biologic therapy like belimumab and rituximab, these are spared for refractory disease. For example, if disease is not responding to this pulse therapy, and these mycophenolate mofetil or cyclophosphamide. Then if the patient is pregnant and she has SLE, you should continue hydroxychloroquine because it is safe in pregnancy. Avoid other teratogenic drugs like methotrexate because methotrexate should be avoided 3 months before pregnancy. 3 months before pregnancy. So, methotrexate should be avoided 3 months before pregnancy. Cyclophosphamide causes premature ovarian failure. So, it should be avoided in patients who want to become pregnant. Monitor for flares and fetal growth restriction. Mostly SLE is suppressed in SLE is suppressed when the patient is pregnant. So there are less chances of these flares, and therefore hydroxychloroquine is more than enough in pregnancy mostly. Prognosis. There is improved survival due to early diagnosis and better management of this disease now. Major causes of mortality are renal failure, infections because patient is on immunosuppressants, so there are a lot of chances of infections, and cardiovascular disease. Cardiovascular mortality is very much high in SLE. So summary, what we have learned. It is a systemic disease and its major features are skin involvement leading to malar rash here and photosensitivity rash, joints leading to arthralgia and arthritis but non-erosive, kidneys involvement leading to proteinuria and lupus nephritis. It has 6 types. CNS involvement, seizures, psychosis, stroke, transverse myelitis, blood, anemia, thrombocytopenia, autoimmune hemolytic anemia, TTP, heart, pericarditis, myocarditis, and lungs, pleuritis, pleural effusion, etc. And the management is hydroxychloroquine and steroids. And if the disease is severe, then you have to give the pulse therapy of these steroids plus cyclophosphamide or mycophenolate mofetil. Especially patient has if involvement of kidneys, then this therapy is very much effective. So this is all about systemic lupus erythematosus.